Hello everyone, and welcome to this small talk about
non-traumatic vascular disorder of the CNS. And the problem with vascular disorder is that the patient may develop stroke. And stroke, by definition, it's an acute episode of neurological deficit, which may range from weakness of a limb up to complete loss of consciousness. And when patient has stroke, you should assess him for the cause and also for the management. The causes of stroke are variable and they can be classified into two major sections. The first one is ischemic stroke, which is due to infarction secondary to vascular occlusion, and may be by a thrombus, which is formed inside the blood vessel, an impulse, which is formed elsewhere and travels to this area, or maybe compression from external source, for example, a space-occupying lesion or brain herniation. And the other section is non-ischemic stroke, which can be an intracerebral hemorrhage or subarachnoid hemorrhage, non-traumatic, or cerebral venous thrombosis. So the outline of this talk will include all these topics, which are all causes of stroke. And starting by ischemic stroke. And the most common cause of cerebral ischemia and infarction is atherosclerosis, which is a physiological process that occurs for all humans, and its course and outcome vary from one person to another according to many factors, including obesity, for example, physical activity, and comorbidities, and so on. Atherosclerosis affects large and medium-sized arteries, and the hallmark of this disease is the formation of a plaque. And the plaque is formed inside the vessel wall, attached to the vessel wall due to slowing of the blood flow. And so it occurs at the site of carotid bifurcation, for example, and distal basilar and carotid siphon and MCA. So where you find a slowing of the blood vessel due to kinking of the vessel or branching, and intimal injury occur, blood element will aggregate at the site, forming the plaque. And the plaque has two main fates. It may fragmented and detached, forming a distal embolism, or may increase in size, forming stenosis, and later on occlusion of the vessel. The first way to find out about the plaque is by ultrasound. It's an easy way to diagnose and characterize the plaques. For example, here is a B mode of the common carotid artery, and you can see there is a soft tissue plaque, which is difficult sometimes to differentiate it from the lumen itself. It is a soft plaque, and soft plaque is dangerous because it may be fragmented and causing distal embolism. Another type of plaque here is an echogenic plaque with no shadowing, and this is a fibrous type. And the most common or the most stable plaque is the calcified one, which is an echogenic plaque and with distal shadowing here. This plaque is very resistant to fragmentation and embolism. The heterogeneous plaque, on the other hand, is very dangerous because it appears as multiple echogenicity, and the hypoechoic part is likely due to an intraplaque hemorrhage. This plaque is liable for fragmentation and distal embolism. And when you assess the plaque, you should assess its surface, upper surface, which should be a dome-shaped or convex-shaped. Okay, but here in this plaque, it is ulcerated, which means that this plaque can give distal embolism. And when two plaques come opposed together, they are called encasing plaques, and they can cause a significant stenosis. So in B mode ultrasound, you should assess the plaque for its type, for its size, and for its surface, either ulcerated or not, and then you should use color Doppler to find out about stenosis. Here, for example, you can find this turbulence flow, and they call it aliasing because of the high velocity turbulent flow at the site of stenosis. And then you should use the pulsed Doppler to find and to measure the velocity of this at this stenotic area. Here, for example, it exceeding 500 centimeters per second, which means a significant stenosis. We have other methods to assess and visualize the plaques and assess the atherosclerotic changes. For example, in CT angiography, like here, is the common carotid artery, which gives off external carotid, which gives branches at the neck, and the internal carotid, which has no branches at the neck. At the origin of the internal carotid, we can see this soft plaque, okay, with marginal calcification, and it causes stenosis of the vessel. We can assess it in multiple and different directions. MR angiography is another way to detect atherosclerotic changes and significant stenosis. For example, here, the problem with MR angiography, it may overestimate the stenotic area, like here in MR angiography and here in digital subtraction angiography. The main advantage of MRA is that you can do it without contrast. Actually, digital subtraction angiography is now preserved for the treatment. For example, here is the significant stenosis at the middle cerebral artery M1 segment, and here after balloon angiography. So we can restore most of the circumference of the vessel by just balloon dilatation. Arteriolosclerosis is another entity which affects small vessels, okay, and so we can call it small vessel disease, and sometimes ischemic leukoencephalopathy, and chronic deep white matter ischemia, and chronic low-grade ischemia. All these terms refer to arteriosclerosis. It's common also in chronic hypertension and diabetes, and it may lead to dementia. The site for arteriolosclerosis is the periventricular white matter. And pathologically, it affects the small vessels by causing collagenous thickening and hyalinization with loss of smooth muscle. This leads to luminal narrowing and stenosis. How it appears on CT? It appears as an ill-defined confluent hypodensity, which are seen mainly at the periventricular deep white matter area. Another case here of advanced arteriolosclerosis. On MRI, the best sequence to visualize arteriolosclerosis is the FLAIR image. As you can see here, there is periventricular high signal intensity deep white matter from ischemia, and sometimes they call this capping of the ventricle. Also, there are multiple other small ischemic foci within the white matter. You can describe it and as a term of ischemic leukoencephalopathy or small vessel disease. The other entity here is vasculitis, which is a group of inflammatory and immune-mediated disease that affects the wall of arteries, veins, or maybe the perivascular space. Vasculitis results in inflammation and fibrinoid necrosis of the vessel wall. Sometimes it may be specific or sporadic, affecting the CNS vessels only, like for example primary CNS angiitis, or may be associated with other systemic vasculitis, like for example rheumatoid arthritis and systemic lupus erythematosus. There are many classifications for vasculitis, and the most common or most popular one is according to the vessel size. Some disease affecting large vessels only, for example in Takayasu arthritis and giant cell arthritis. Other disease affecting medium-sized arteries, for example polyarthritis nodosa and Kawasaki disease. And other affecting small-sized vessels, for example in microscopic polyangiitis and granulomatosis with polyangiitis, which is the recent term for Wagner granulomatosis. Wagner granulomatosis is not used anymore. Other vessels or other vasculitis affecting any size of vessels, for example, Behçet's disease. And some vasculitis associated with systemic disease, for example, as we mentioned, rheumatoid and systemic lupus and antiphospholipid antibody syndrome. Because of the pathology of vasculitis which affect the vessel wall may be thickened and also may be fragile and prone to rupture. So we have many findings we can see with vasculitis, for example, vessel wall thickening, stenosis and occlusion, for example, in Takayasu, giant cell and moya disease. Also, we can find out some aneurysmal dilatation, like for example, polyarteritis nodosa, deep white matter ischemia from affection of small vessels, vascular territory infarction, and when affecting large and medium-sized arteries, intracerebral hematoma, microbleeds, and subarachnoid hemorrhage from ruptured aneurysm, venous thrombosis because some vasculitis affecting the artery and the veins, like for example Behçet's and antiphospholipid antibody syndrome. And finally, we can find some leptomeningeal enhancement in case of sarcoidosis and TB. Here is a young female which has she had systemic lupus erythematosus and came with encephalopathy, and we found on MRI in FLAIR images multiple hyperintense lesions scattered all over the white matter, subcortical white matter, and also in the basal ganglia, and this was from vasculitis or vascular affection. Another child here which has primary CNS angiitis, and as you can see here there is an acute infarction of the lentiform nucleus, also from vasculitis. So vasculitis and atherosclerosis and arteriosclerosis, all of them can cause infarction, and infarction is an interrupted blood flow to the brain which causes a neurological deficit. Infarction can be large vessel infarction, lacunar infarction, or maybe watershed. And watershed zones are the zones which lie between two arterial territory. So these watershed zones are prone to ischemia when there is sudden drop of the blood pressure. Sites of infarction, you should be aware of the vascular territory, okay, and the watershed zones. Acute infarction can be detected by diffusion weighted image, which appears as hyperintense restricted diffusion with low signal on the ADC map. We will talk about that later on. And also in perfusion weighted image due to decreased perfusion. Okay, and when comparing the diffusion and perfusion, we can reach what's called a penumbra or mismatched diffusion perfusion. Okay, we will talk about it later on. On CT, the acute infarction has many signs. For example, here in the dense MCA sign with loss of gray-white matter differentiation and hypodensity. This is a case of left MCA infarction in the acute stage. Another sign is insular response sign, or what's called loss of insular response sign due to hypodensity of the insula and external capsule with loss of corrugation of the Sylvian fissure. Compare here with the loss of insular response sign with the normal side. So let's talk about diffusion, and here is a section of a cell membrane, and we can find two types of channels. Channels which is opened, okay, and channel with it mediated by ATP. Sodium molecules are seen outside the cells in the extracellular space, but it can go inside the cell freely through this channel. When sodium goes inside the cell, water will follow. So the cell will be the sodium will come inside the cell together with water, and the cell become loaded with iron and water. cell need to regulate its osmotic pressure by getting the sodium outside the cell through this channel. This channel is actively mediated by ATP. And when get the sodium outside the cell, the water will follow also. So the cell will regulate its osmolarity. So what happened when you cut off the blood supply to this cell? This channel will not be affected, while this channel will be affected and failed. So sodium goes inside the cells with water, but it doesn't go outside. So the cell will be ballooned and distended with water, and later on rupture. And that's what's happening. For example, here these are cells and extracellular space with free movement of water molecules at the extracellular space. When infarction occurs and vessel occlusion occurs, the cells become ballooned like this with restriction of the water molecular movement in the extracellular space. And we call it restricted diffusion. So this is the mechanism of restricted diffusion in infarction. The images of diffusion weighted is like this one, with infarction at the basal ganglia here, caudate nucleus and lentiform nucleus, and it appears as bright signal on DWI. And you should compare it with the ADC map apparent diffusion coefficient, like here, and it will be dark signal on ADC. So bright signal on diffusion, dark signal on ADC, it's a true diffusion restriction. The other new technique which used is the perfusion weighted image. And here an illustration from radiology assistant in which there is a thrombus in the middle cerebral artery. This thrombus causes acute infarction at area, this dark area here, and ischemia of this larger red area. And this larger red area is called penumbra. And your aim is to restore the blood flow to this penumbra to salvage this area from infarction. Here are examples here. I'll give you two examples, and this one is an infarction in the periventricular white matter detected by diffusion weighted image. And when doing perfusion, there is a larger area of ischemia. So there is diffusion-perfusion mismatch. And if this patient was ignored, like what's happening to this patient, it will develop an infarction in all this ischemic area here. But actually, if the patient was treated as early as possible, you may salvage this ischemic region or ischemic penumbra. But unfortunately, this wasn't the results. So this is called diffusion-perfusion mismatch. Another diffusion restriction at the insular cortex and external capsule here, then acute infarction, and on perfusion there is a very large area of temporal lobe ischemia. Again, your aim is to restore the blood flow to this area to protect this area from being infarcted. Subacute infarction is an infarction after 2 days up to 2 weeks, and at this stage hemorrhagic transformation may occur. Also, the cytotoxic edema become more evident, and it can cause mass effect, and if you inject contrast you will get a gyral enhancement. Some example of subacute infarction here is right frontoparietal subacute infarction with mass effect and compression of the ipsilateral lateral ventricle. Another case here, after contrast injection, you can appreciate now the gyral enhancement pattern. And here is a malignant infarction. They call it malignant infarction because there is marked toxic edema, okay, which causes compression of the ipsilateral ventricle and subfalcine brain herniation. And on CT angiography, we can find no enhancement or no vessels at this site, and even no meningeal vessel, because this patient had common carotid artery occlusion. So the internal and external carotid, both of them show no flow. And this patient should be treated by craniectomy. They should open here to relieve the pressure and the brain to the outside. And here is an example of hemorrhagic transformation of left front parietal infarction. Lacunar infarction is another type of infarction which by the size it's less than 1.5 centimeter or 15 millimeter. It occurs at the basal ganglia, the thalamus, bones, and periventricular white matter, and mainly in elderly patient more than 55 years old. And you cannot differentiate acute from chronic lacunar infarction unless you do a diffusion weighted image to see the restricted diffusion. Lacunar infarction sometimes misdiagnosed and cannot be differentiated from Virchow open spaces, which is a normal variant. So sometimes you have Virchow open spaces and you misinterpret it as lacunar infarction. Example here for lacunar infarction, which is seen at the right internal capsule, anterior limb of internal capsule here, and this one is chronic because there is a negative mass effect on the frontal horn of lateral ventricle. There is also another chronic infarction in the temporal region. Diffusion weighted image showing a lacunar infarction here in the posterior limb of the internal capsule. And as I told you, you have to get ADC with a diffusion weighted image because infarction should be bright signal here, like here in thalamic infarction, lacunar infarction, and it should be dark signal on ADC map. So it is true diffusion restriction. Moving from ischemic stroke to the non-ischemic stroke. And we'll start with hypertensive hemorrhage, which is a non-traumatic intracranial hemorrhage secondary to long-standing hypertension. So chronic hypertension causes fibrinoid necrosis of the vessel wall, which create microaneurysms, and due to fluctuation of the blood pressure, these aneurysms can rupture and result in hemorrhage. And take care of this hemorrhage because this hemorrhage is non-lobar, which means it's deep hemorrhage, not superficial. The site for hemorrhage is the putamen, thalamus, brainstem, and finally the cerebellum. When intraventricular extension occurs, it's a bad prognostic sign and it indicates high mortality. Hypertensive hemorrhage should be diagnosed and followed up by CT. There is no rule for MRI. And you can use a CT angiography to detect what's called angiographic spot sign, which may indicate progression and expansion of the hematoma. Here is a thalamic hypertensive hemorrhage with intraventricular extension. Here is a putaminal hemorrhage on MRI, flare images surrounded by edema and with mass effect. Another thalamic hypertensive hematoma with intraventricular extension, and when you give contrast you can find this angiographic spot sign which indicate active bleeding, and it's a predictor of hematoma expansion. So let's talk about blood evolution on CT and MRI. On CT, when the blood leaves the vessels and become accumulated within the tissue, it raises its density. Because of accumulation of the blood vessels, mainly the heme proteins may increase the density of the tissue. And this occurs within few hours. Later on, fibrin accumulate within this hematoma and result in what's called clot retraction. And the hyperdensity become centered within the lesion and smaller in size. The region is now surrounded by edema, and this occurs within few days. Later on, the macrophages will be at this area, engulfing the blood elements, and the hematoma will be dissolved, maybe leaving some areas of encephalomalacia and the negative mass effect like here, and this occurs within few weeks. On MRI, it's more complex than this, because MRI has many factors which affecting the bleeding, affected by bleeding, okay? But the major factor here is the iron atom. And iron is combined with globin to form the heme protein, okay? And it can exist in different forms. For example here, oxyhemoglobin, which is hemoglobin attached to the oxygen, okay? And the iron atom will be in the ferrous state. At this state, the iron has no unpaired electron at its outer shell. So this compound is diamagnetic, which doesn't affect the magnetic field. Another compound here is when the hemoglobin loses its oxygen, it becomes deoxyhemoglobin. And the iron atom will be in the ferrous state also, but it will contain two unpaired electrons in its outer shell. Two unpaired electrons means that they will create inhomogeneity of the magnetic field. We call it susceptibility. And this compound is paramagnetic because it will affect the magnetic field. The deoxyhemoglobin by time will undergo an oxidative process and will result in what's called methemoglobin. And methemoglobin, the iron atom will be in the ferric state, and it will contain 5 unpaired electrons in its outer shell. So methemoglobin is a paramagnetic material or paramagnetic compound that will affect the magnetic field. Methemoglobin will be further undergo oxidative denaturation process and will result in what's called hemosiderin. And iron will be still in the ferric state, but it will contain many unpaired electrons in its outer shell. And hemosiderin is considered super paramagnetic material, so it will create more and more susceptibility. By this information, we can understand now this table. So hyperacute blood, which is bleeding in the first 12 hours, and here the hemoglobin in the oxy state, and it is inside the RBCs. So it will not affect the signal of the T1. T1 signal will be iso signal, okay, and T2 signal will be derived from the fluid in the plasma. So it will be bright signal. No susceptibility here. In acute bleeding in the first 1 to 3 days, the hemoglobin will lose its oxygen and become deoxyhemoglobin, but still inside the RBCs. Again, no effect of T1 signal, which will be still iso intense signal, but the deoxyhemoglobin with the unpaired electron in the ferrous atom will create some susceptibility, so it will be low signal on T2. In subacute blood, we divide it into early and late stages. And subacute blood is characterized by formation of methemoglobin. The difference between them is when methemoglobin is inside the RBCs or outside after rupture of the RBCs. Methemoglobin itself will shorten the T1 time and become bright signal on T1 because it shortens the T1 relaxation time. On T2 it's different because methemoglobin with ferric iron contains 5 unpaired electrons on its outer shell, so it should create susceptibility. And it can create this susceptibility while it's inside the RBCs because methemoglobin molecules are aggregated together, and this is called compartmentalization. So as long as the methemoglobin inside the RBCs, it will create susceptibility and will be low signal on T2. After rupture of the RBCs, the methemoglobin becomes dispersed within the medium, so it will lose its susceptibility effect, and the signal will be derived from the fluid in the hematoma. So T2 will be bright signal on the late subacute stage. On chronic bleeding, after 1 month, hemosiderin will be the main component here, and it's super paramagnetic, so it will increase the time of the T1 relaxation time, so it becomes low signal on T1, and it shortens the T2 relaxation time, so it will be dark signal due to susceptibility. So hemosiderin will be dark on T1 and T2. So let's take examples here. In the up row, we find this hematoma on the right occipital region. It's iso on T1 and hypo on T2, so it is acute blood. On the bottom row here, the same hematoma after a few days, and now it is hyperintense T1 and hyperintense T2, so it is late subacute bleeding. Another child here with left frontal intraparenchymal hematoma, as you can see here, and it is iso on T1 and the bright signal on T2 because it is hyperacute hematoma with surrounding edema. Another thalamic hematoma, thalamic hypertensive hematoma like this one, which is more complex because the center of the hematoma is different from its periphery. And as you can see, the center is iso or slightly hyperintense and on T1 and low signal on T2, which means it's acute or early subacute bleeding. But the periphery of the hematoma is bright signal on T1 and bright signal on T2, which means it's late subacute blood. Bear in mind that the hematoma ages from the periphery to the center, so the periphery is more advanced. Another topic in stroke is non-traumatic subarachnoid hemorrhage. And subarachnoid hemorrhage is the presence of blood in the subarachnoid space. It can be seen in the intrahemispheric fissure, sylvian fissure, and basal cisterns, and even cortical sulci. The main cause of subarachnoid hemorrhage is trauma, and the main cause of non-traumatic subarachnoid hemorrhage is aneurysmal rupture. Also, we have other causes like vasculitis and spontaneous subarachnoid hemorrhage. And the patient will come suffering from the worst ever headache and neck stiffness. How to see blood in the subarachnoid space? It will appear as hyperdense on CT, and on MRI you need to do FLAIR image or T2 star image, and it will be bright signal on FLAIR and low signal on T2. Here is a CT, non-contrast CT. You can see a hypertense material which is seen filling the basal cistern, suprasellar cistern, interpedunculaar cistern, ambient and quadrigeminal, and also extending to the sylvian fissure. Here is a FLAIR image, and you can see the hyperintense blood which is seen filling the sylvian fissure on the left side, and compare it with the sylvian fissure on the right side, which contains no blood. And the main cause of the non-traumatic subarachnoid is aneurysms. So aneurysm is a focal dilatation of the vessel wall. It may be saccular or rounded, fusiform, or dissecting. And when aneurysm exceeds 2.5 cm, we call it giant aneurysm. And giant aneurysm may rupture and may cause mass effect. When aneurysm is due to inflammation or infection, like for example bacterial endocarditis, meningitis, or septic thrombophlebitis, we call it mycotic aneurysm. And we should differentiate between true aneurysm, which is dilatation involve all layers of the vessel wall, which are the intima, media, and adventitia, or pseudoaneurysm, which is dilatation due to or involving less than the whole layer. For example, it may involve one layer, the adventitia only, or the adventitia and media layers only. And pseudoaneurysm is usually post-traumatic. There is also what's called dissecting aneurysm, and it is due to intimal flap, which is separated from the vessel wall and creating what's called pseudolumen. Here is an illustration of aneurysmal types. Here is the saccular aneurysm here, which arises from one side of the vessel wall, and it has a neck. It can be treated by intervention neuroradiology, by catheter, and injection of coils here inside this aneurysmal sac, which will cause fibrosis and the sac will shrink. On the other hand, in fusiform aneurysm, it involves the whole circumference of the vessel wall. It has no neck, and it should be treated by stents, starting from here to the other side and bypassing this dilated sac. And here is the aneurysm after rupture. MRI flare images showing a middle cerebral artery aneurysm, saccular aneurysm with adjacent area of bleed. And here is MR angiography of the same patient, and there is the saccular aneurysm. Also CT can be used here, CT angiography, for example another MCE aneurysm at its bifurcation point, another saccular aneurysm, and this is a DSA of the same patient, showing this saccular aneurysm. And when you see aneurysmal dilatation at the interpeduncular cistern here, between the two cerebral peduncle, okay, it's very characteristic for what's called basilar tip aneurysm. So here is the vertebral arteries, and this is the basilar artery, and this is the posterior cerebral artery, and at the tip of this basilar artery arising for this saccular aneurysm. Fusiform aneurysm usually affect the vertebrobasilar system, and here, for example, is a DSA of basilar artery, as you can see here. Dilatation involving mainly the whole vessel, and it can be detected on non-contrast CT, and it can compress the brainstem and causing manifestation. But sometimes we can find this aneurysm as incidental finding in non-contrast CT. Again, this is a fusiform aneurysm of the basilar artery. Regarding carotid dissection, okay, this is an image of or a video of a case which was quoted on ultrasound. I'll show you. And this is the intimal flap, and this is the common carotid bifurcation, and internal carotid artery. So again, you can see the intimal flap moving during the blood flow. Moving to another topic, which is cerebral venous thrombosis, and it is thrombotic occlusion of dural sinus, cortical vein, or deep veins. The venous system of the brain is divided into superficial and deep venous systems. Okay, anyone can be occluded or thrombosed. Site for thrombosis, the most common is the superior sagittal sinus and transverse sigmoid cavernous sinus, adjacent cortical veins, or maybe the deep veins, including the internal cerebral vein. When the cerebral veins are occluded, it results in congestion of the brain parenchyma due to impaired venous drainage and may cause hemorrhagic infarction. In non-contrast CT, the hyperdense dural sinus or cortical vein become hyperdense due to thrombus and is called it cord sign. And when we go for contrast, okay, this thrombus will not enhance. while the dura around will enhance, and it gives a sign called empty delta sign. On MRI, we can also see the thrombus and give a timing about it, because acute thrombus, it appears as ISO on T1 and hypo on T2 due to the oxyhemoglobin, just like hemorrhage we talked about before. Okay, and on subacute thrombus, it becomes hyperintense on T1 and T2 due to extracellular hemoglobin. So we have another idea of the timing of this thrombus. Also, if we give contrast, we will get the empty delta sign after contrast enhancement. And MR venography, which is done without contrast injection, can show a shaggy venous sinus or even absent flow. Here is the empty delta sign. This is the thrombus inside the superior sagittal sinus with a surrounding enhanced dura. Another empty delta sign on MRI, again enhanced dura, while the thrombus is non-enhancing. And here there is also parenchymal hemorrhage and parenchymal edema. A T1 and T2 weighted image showing a thrombus of the left transverse sinus, which is iso-intense on T1 and hypo-intense on T2, so it is acute thrombus. This is another patient, also T1 weighted image and T2 weighted image showing thrombosed left transverse sinus. The thrombus is hyperintense on T1 and hyperintense on T2, which means it's a subacute thrombosis. The result of sinus thrombosis is hemorrhagic infarction, as you can see here. And when we do an MRI for this patient, we detected thrombosed transverse sinus. So hemorrhagic infarction in non-arterial vascular territory, you should consider venous thrombosis. And now we will talk about AV vascular malformation or arteriovenous malformation, which is abnormal network of arteries and veins with no intervening capillary bed. It occurs in young age, 20 to 40 years old. It may be parenchymal, dural, or mixed. It can occur anywhere at the brain or spine. And it is described as bagoform appearance. AVM can be very big, but without mass effect, unless hemorrhage occurs. So, what is AV malformation? This is a normal arterial venous junction. Okay, so arteries will end into arterioles, and arterioles into arterial side of capillaries and venous side of capillaries, then venules, and so finally the veins. And this is due to, and this will cause the grading down of the pressure, high pressure inside the arteries into low pressure inside the vein. And this downgrading of the pressure will help into perfusion of the tissue with oxygen. In arteriovenous malformation, you will directly connect the artery to the vein. So the high pressure inside the artery will be transferred into the vein directly. And this will result in distension and tortuosity and elongation of this vein due to its new high pressure. And this will also impair the oxygenation or the tissue perfusion. How it appears radiologically, here is the non-contrast CT, and as you can see, some hyperdensity here at the left parietal parasagittal area. And when you give contrast, and this is what we call bagoform appearance. You should assess this malformation, and you should get the venous drainage and the arterial supply. Here is an MRI T2 image. and it shows right frontal AVM with draining veins to the superficial venous system, and this is what we call a bagoform appearance. On T1 weighted image, show you the same nidus or the same AV malformation. Okay, but there is also engorged cortical veins from the high pressure. And the best sequence to detect vascular malformation, in my opinion, is the susceptibility weighted image, which is sensitive to the deoxyhemoglobin presence inside the vessels. Here is the susceptibility weighted image of the same patient, and it shows the AVM with deep venous drainage as well as the superficial venous drainage. And this is the nidus, and this is the dilated vessel. So this AVM has dual venous drainage to the arterial and the deep system. Note that the engorged cortical vein as compared to the other side. Cavernous malformation is another entity of vascular malformation, and it's a benign vascular hamartomas with mass-like of closely immature blood vessels, and sometimes there is intralesional hemorrhage, and it contains no neural tissue. It can occur anywhere in the brain or spine, and on MRI it has a characteristic popcorn appearance, especially on T2 weighted image. It appears on CT as a hyperdense, well-defined, well-localized hyperdense lesion, which is stationary over years, and you can find some foci of calcification. And on MRI, it appears, as I said, as a popcorn, multiple intensities inside, and with characteristic peripheral rim-like hemosiderin ring. And the best way to find out about vascular malformation is by T2 star, as here, with the pluming artifacts or blooming effects, or the SWI sequence, which appears like this, and and the lesion appears as well defined as you can see here. So both of them are cavernomas. And the last thing to mention is the developmental venous anomaly, or DVA, and it's also called venous angioma, and it's considered now the commonest vascular malformation of the brain. It is an anomalous vein which drain small veins, okay, into a large collecting vein, and this vein will drain into dural sinus or deep veins. The appearance of small veins draining into a larger connecting anomalous vein is called caput medosa or medosa head. It most commonly occurs at the frontoparietal region and cerebellar hemisphere. This lesion rarely bleeds, so it's considered leave me alone lesion, because if you suspect it is AV malformation and you go angiographically and inject material inside it and occlude this vein, you may result in venous infarction because it drains an area of the brain which may have no other venous drainage. So consider it as a leave me alone lesion. Sometimes in conventional MRI it's very difficult to detect it, and here you can see this thin line of hypointensity that traverse the cerebral hemisphere. So you should get the appropriate sequence, which is the SWI, as I told you before, and this is the same patient, and you can see this is the vein, this is the anomalous vein, which drain into the deep veins, subependymal veins. And the appearance of small veins that are radiating into an anomalous vein is called caput medosa, as I told you before. And here is another vein anomalous which is draining this frontal area by small radiating veins, is called caput medosa again, and this vein itself is drained into the deep subependymal veins. By this I reach the end of this talk, and I hope you enjoyed, and thank you for listening. Goodbye.